SABR or SBRT, they give good results in selected patients, but for those who are not fit for surgery. Stage 4 is metastatic and stage 3B is advanced. Hence, they will require systemic therapies. Stage 3A, they come in the category of locally advanced and will need a sandwich treatment or in the form of a combination of surgery with radiation and chemotherapy. However, multidisciplinary team discussion is a mandate prior to initiation of any kind of treatment in these patients. Another entity in the lung cancers is nothing but pulmonary metastasis. It is when there is a primary from a non-thoracic origin, for example, colorectal cancers. It is the primary is controlled. The tumor it has been an R0 resection or it's a cancer free for more than 2 years, and there are metastasis either in one of the organs apart from the lungs. But the prerequisite has to be that the non-thoracic metastasis also have to be a controlled metastasis. In these kind of situations, then they become surgical candidates, and you prefer and they would require metastasectomy. So this is the video of a pulmonary metastasectomy where the patient had presented with a controlled primary of a bony chondrosarcoma of the hip, but had bilateral pulmonary mets or bilateral lung mets, and since the primary was controlled and the lung mets were not, so we performed the same setting, bilateral uniportal VATS, or we performed a thoracoscopy and did a metastasectomy. So this is the video of one side of the lung. So very classic picture, the classical appearance of a sarcoma as a pale yellow appearance and multiple, pale yellow protruding appearance on the on your camera. Now we are passing through the, so we are performing a wedge of this metastasis, taking into account that we get margins free, which means any metastasectomy has to be a R0 resection. So coming to the lung cancer screening, which is what are the NCCN guidelines for it? Low dose CT scan is recommended by the National Cancer Comprehensive Network. To whom do we recommend, or to whom do we offer the lung cancer screening? To patients belonging to the age group of 55 to 74 years of age with a chronic smoking history of about 30 back years, or if the patient is a former smoker but have quit within 15 years. That means he's recently quit. Or if the patient's age is more than equal to 50 years, but with 20 or more pack years smoking, either at the current or a former smoker, and whose risk for lung cancer is more than 1.3%. What are the key risk factors? Personal history of a cancer or any lung disease, then family history of lung cancer, exposure to radon, exposure to any other carcinogens, or an occupational exposure as discussed in the past. Quick word on some of the benign lung tumors and the WHO classification, which has been already in practice. Benign epithelial tumors are nothing but adenomas and papillomas, and there are some soft tissue tumors like chondromas and fibrous tumors. Then there are some tumor-like lesions like tumorlets or Langerhans cell histiocytosis or inflammatory pseudotumor. Then there are some others, for example, hematoma, which is very, very common occurrence, or a clear cell tumor. Trachea or the airway, and what are the diseases affecting trachea? Benign tracheal stenosis, most common. So normal 2 centimeter trachea, it has 100% of peak expiratory flow rate. A 10 mm opening provides 80% of the peak expiratory flow rate. However, if, for a 5 mm opening, only a 30% of expiratory flow rate is achieved. And this is nothing but the pathophysiology of the symptoms due to benign tracheal stenosis. It is most common due to prolonged ventilation and tracheostomy or a tracheotomy or a trauma. We also call it as post-intubation tracheal stenosis. Tracheotomy leads to transmural defect of the ventral part of the cervical trachea, which gets colonized by bacteria and then leads to local necrosis. Once the tube is removed, this defect then closes by secondary scar tissue, which then contracts on each respiration. Low volume pressure curves of the ventilation tubes, they induce this reaction. Deeper destruction and infection of the tracheal wall will lead to ring of granulation tissue and stenosis further. Mostly it occurs in the cervical or the middle part of the trachea. Stridor and dyspnea would be the presenting symptom. Resection of the pathologic segment with an end-to-end anastomosis is the mainstay of the surgery. When the larynx is also involved, then you will have to remove partially the anterior cricoid cartilage or divide the larynx, and along with the placement of the silicone stent. Primary neoplasm of the trachea are either squamous cell or adenoid cystic carcinoma. If benign, then they can be hemangiomas or hematomas. Metastasis, however, are very rare. Squamous cell carcinoma, they are most common, they are multifocal in 10% and they behave very similar to lung. Adenoid cystic carcinoma, they are cylindroma, also called the cylindromas. They are well differentiated, they are slow growing, they are central in location, that is either in trachea or carina or main bronchi. They breach the cartilaginous plate. Then perineural invasion and invasion into the vascular structures are very, very common, and they affect the prognosis when found. They can have multiple recurrences with late metastasis. Dyspnea, hemoptysis, dysphagia, and host are some of the symptoms. They present very late. They present mostly in the smokers, and the male to female ratio is almost similar. When encountered with these kind of tumors, what you need to do first is first ideal investigation is a chest CT followed by a bronchoscopy to delineate the location of the tumor. PET CT would be required for a tumor staging. Tissue biopsy is a must. Once all the investigations are confirmed and metastasis is ruled out, surgery is the mainstay. It has to be followed by radiation. The radiation provided R0 resection is achieved and when the tumor was resectable. Maximum length of the trachea that can be excised is about 5 centimeters. Adjuvant radiation, anyhow, it improves survival, especially for R+ resected tumors. Coming to one slide on just principles of tracheal surgery, it's very important. It is performed under general inhalational anesthesia. It's with a special armored tube for intubation. If the stenosis is longer, then the tube is positioned just above the stricture. Subglottic stenosis needs dilation before the intubation. Rigid bronchoscopy may be required for the purpose of diagnosis or a dilation, biopsy, morcellation for any of these steps. Cervical approach is used for upper half of the trachea and especially for pits, and thoracotomy approach is used for cranial lesions or the lower half of the trachea. Maximum amount of trachea that can be resected is 5 centimeters. However, you might need to achieve tracheal mobilization by any of these maneuvers like hyoid release, mobilization of the right hilum, division of the pericardium surrounding it. Recurrent laryngeal nerve is the most common injury, is the most common complication because it can occur while circumferential dissection around the tracheoesophageal groove. What are the contraindications to surgery in inadequately treated laryngeal problems? Or if there is a need for ventilatory support or permanent tracheostomy, especially in cases of myasthenia gravis or quadriplegia-like conditions. Or if the patient is on high-dose steroids where there is a healing issue or to be contemplated in post-operative period, or if it's an inflamed tracheostomy. So coming to pulmonary infections, very common, especially in the Indian region. Bronchiectasis, it is a chronic respiratory disease characterized by a clinical syndrome of cough with extensive and foul-smelling sputum production, infection, and radiologically, most important is the abnormal permanent dilatation of bronchi. Very, very important. Predisposing factors are cystic fibrosis, alpha-1 antitrypsin deficiency, cartilaginous syndrome, foreign body obstruction.